Hello?
And the blood vessels. Since shock is a perfusion problem, and as defined, shock is not a disease, it is a state. So it is a condition. Therefore, any problems with these three elements can lead to the state or the condition of shock. For instance, if the pump fails, there are two ways a pump can fail: directly or indirectly. An example of a direct pump failure is an MI. So you did this in MedSurg 1, I believe. And another way it can fail directly is from structural damage. Let's say valve disorders. We talked about that last semester. And another direct pump failure is a dysrhythmia. So you have VTAC, VFib, for instance. You have um, a, a direct pump failure there. Indirect are the other conditions which we'll talk about this semester are PE. Another is a tension pneumothorax. Another is, it could also be by, oh, we talked about it last semester, from a complication of pericarditis, which was cardiac tamponade. So let me differentiate between direct and indirect pump failure. So in direct pump failure, the heart itself died here. So some damage here, a valve disorder, for instance, caused it to fail. It failed to function as a pump. The reason occurred within the heart itself, meaning the pump itself is the problem. In indirect pump failure, this is now structures outside the heart, meaning it's not the heart itself. The heart is working fine. It's the structures around it. For instance, in cardiac tamponade, we have an accumulation of fluid or blood there, right, around the pericardium. So as the fluid there builds up, it squeezes the heart, causing it to fail. So it wasn't technically the pump's fault. It was the structure in cardiac tamponade. It was the fluid accumulation in the sac around it that caused it to fail. In tension pneumothorax, because the heart has to share the thorax with two lungs. So the mediastinum here was also the same way as cardiac tamponade was squeezing the heart. This time it's not the pericardium, but it was the lungs. So the pleura of the lungs filled with air, blood, or whatever, causing the buildup of positive pressure inside the thorax, compressing the lung. So once you collapse the lung, it will move. So if the positive pressure builds even more, it will now shift the mediastinum. It will push the heart outside of the mediastinum. So if you do that, then of course you compress the vessels there. You will compress the superior vena cava. You'll compress the inferior vena cava, and until the patient dies because there is no cardiac output. So in direct pump failure, we call this cardiogenic shock because it is the heart itself that failed. Cardiogenic. Indirect pump failure, we call this obstructive shock because something is obstructing the heart function. Blood volume problem, this is hypovolemic shock, meaning you lost blood or fluid. Okay, so this is fluid / blood loss. Then finally, vessel problem. This is what we call distributive shock. Because unlike in most other shocks, the ones we talked about here all these guys will stimulate sympathetic nervous system, causing vasoconstriction. here in distributive shock, there are three weird conditions happening here, all caused by severe inflammation. Hope you can read that. Severe inflammation leading to vasodilation. So instead of increasing systemic vascular resistance in order to generate higher blood pressure, here in distributive shock, we have massive vasodilation as a result of severe inflammation. Number one is anaphylactic, because in anaphylactic shock, you have severe sensitivity to a substance, a drug, or food, causing severe systemic inflammatory response. You have a high number of histamines causing increased capillary membrane permeability. You have leaky, your vessels become leaky, and then that results in shock, because now imagine a really large diameter blood vessel and you don't have enough blood to fill those things. So therefore, no vascular resistance, no blood pressure. The second is septic shock. Septic's the same in anaphylactic. Septic, you also have severe inflammation there, but among all the types of shock, septic will be the odd one out. We'll discuss that later. And then the third one, although in neurogenic shock, there is no inflammation involved. So only these two here, this one and this one, is involved with inflammation. In neurogenic, here there is loss of sympathetic tone here. Loss of sympathetic tone, meaning there is no vasoconstriction here. So number one example or cause of neurogenic shock is spinal cord injury. So this one is unique because instead of having a sympathetic response because your blood pressure drops, in spinal cord injury, because there is the signals to and from the spinal cord, because all messages going to the brain has to travel through the spinal cord. Because of the injury, there is no sympathetic tone. What you'll have instead is parasympathetic response, which is the opposite of sympathetic. So instead of having vasoconstriction, you will have vasodilation. So all these three here, 1, 2, and 3, all have vasodilation instead of vasoconstriction. Now let's return to your textbook. Are you guys with me? You're so quiet. Any question?
We're listening.
Okay.
No questions.
All right. So here is shock now. Chapter 14. So again, the shock is not a disease. This is a condition. So the causes and the types we discussed for the first few minutes are all states now. So if you come or you develop a state wherein your body, especially your heart or your vessels, are unable to supply this continuous need for oxygen for cells, you go into shock. Doesn't mean you'll die right away. You just switch though. So instead of we normally having an aerobic metabolism, your cells now switch to anaerobic metabolism, which now causes a cascade of damage to the cells, because now you switch from aerobic to anaerobic metabolism. That will build up lactic acid accumulation. So therefore, you'll go into severe acidosis, and it's just a matter of time when cells start to die. You'll have severe hyperkalemia as a result, and you'll have a few technical causes of death, but your overall cause of death is from shock, whether it's cardiogenic, obstructive, anaphylactic, or neurogenic shock. Any questions so far? So our concepts here in the chapter will be all about these guys here. It's about maintaining cardiac output. We'll have to devise methods into deliver oxygen to increase oxygen delivery, reduce oxygen consumption, and of course, pay back oxygen debt. So oxygen debt is like student debt or taxes. No, they never go away. You have to pay it. Even when you're dead, you still have to pay back what you owe the government. Okay, so student loans, well, they can be forgiven, but no, generally speaking, no, it follows you to the grave. Oxygen debt has to be paid or else you'll die. That's a different thing. Okay, so we need to maintain cardiac outputs. Let's review certain terms. So what is preload again, Miss Esther?
Preload is the amount of blood in the ventricles at the end of the diastole. It is the reflection of... I'm sorry?
So if we go to the three elements of perfusion, blood volume, and blood vessel, which one is preload?
On the blood volume is preload.
All right, very good. So we understand preload is the blood volume. So we can control preload in order to increase blood pressure. Okay, it really depends on the type of shock though. Meaning in all shock, you can't just say, oh, I'm going to increase preload. Not all the time. So here, these three here are the elements of perfusion. So we have blood volume, blood vessels, and the pump. All right. So again, these are the three that we will control when treating shock, because these are the three things also that are the causes of shock. So therefore, we have to manipulate these three. Again, how we do that is going to depend on the type of shock. Afterload, of course, this is referring to the blood vessels, okay, because it's defined as the resistance of blood flow. Okay, so the resistance that the heart must meet in order to pump that preload through the vessels. And contractility, of course, is the force of the mechanical force of contraction. This obviously refers to the pump. All right. So we talked about hypovolemic. I described it, that this is a loss of more than 30% of your fluid or blood. These are some of the causes. Trauma, say in Giselle's neighborhood, which is, what block are you in, Rikers, Giselle?
Rikers? I'm in Elmers.
Oh, I thought you're from Rikers Island.
No, that's your other friend.
Oh, okay. So you have gunshot and knife injuries there. So trauma, it could be any trauma. It doesn't have to be that violent. Okay. Other causes are, you have a ruptured aneurysm, for instance, or aortic dissection, what else do we have? A ruptured appendix, right? Or a fractured hip, for instance. So any method where you can lose fluid and or blood. Surgery is another example. Don't confuse it. Just because you have heart surgery, for instance, and you go into fluid loss, what do you have? Are you having, blood loss. So you had open heart surgery and then you're bleeding. What is your shock? Is it cardiogenic or hypovolemic?
Hypovolemic, right?
That one is hypovolemic. Okay, this one just happens to involve the heart. All right, so don't get confused. Cardiogenic, as already described, this is the pump itself. Okay, not the structures around it causing it to fail. It's the heart itself. So number one exemplar For example, is an MI. An MI will cause direct pump failure. Other causes are, as already stated, dysrhythmias, VFib, VTAC, and we also have um, valve disorders, for instance, case particularly aortic or mitral valve problems. Those can cause cardiogenic shock. Distributive, I
Professor,
already,
sorry, cardiac tamponade, that's also cardiogenic shock?
no. As already described, it falls under obstructive because it's
Sorry,
not
right,
the
obstructive.
heart
Yes.
itself. Yeah, it is the
Thank you.
structure around it. Okay. So distributive shock, as already enumerated, these are the three: sepsis, anaphylactic, and neurogenic. Please, I disagree with this. Why the author puts spinal shock? Because spinal shock is not shock at all. This is not involving hemodynamics. Spinal shock is a loss of neurosensory function after spinal cord injury. So erase this. This should not be here. Spinal shock is not talking about blood pressure at all. A spinal shock is a temporary loss of neurosensory function, meaning you become paralyzed, but it's not permanent though. So this is not the shock per se that we're talking about. It's not the oxygen death. All right, is that clear?
Mm-hmm.
All right, so erase that spinal shock there. That doesn't belong there. Neurogenic shock is the shock that results after spinal cord injury. And obstructive shock, these are the examples. So I mentioned cardiac tamponade, tension pneumothorax, the pulmonary embolism, a really massive one though, because not submassive and low risk. It's only the massive PE that causes obstructive shock. The stages we're talking about here only applies to all shocks except septic shock. Again, all shocks follow these stages right here, but not shock. A septic shock follows a completely odd and different pattern. That's why it has a very high mortality, because it's not very um, predictable. Okay, so, a septic shock can be deceiving. Okay, it doesn't follow the normal signs of or stages of shock. Initial, I don't really like to discuss this because there's not much here. There's no serious damage being done, meaning if we discuss this thing, it could be us. Let's say we're out in the sun, for instance. All of us at one point will be subjected to the initial stage, but because we have good compensatory mechanisms, we don't proceed to the non-progressive stage, which is the second stage. So we'll skip the initial stage because the symptoms start from the non-progressive stage. This book, here are, by the way, your causes. So there'll be a question here on the exam asking you, select all apply, which ones are causing which shock. All right, so you have good examples there. Compensatory stage. This is also called the non-progressive stage. The next stage is called progressive, this one. So compensatory is also called the non-progressive stage. The signs and symptoms are easy because by the name itself, it says compensatory. So these are all the symptoms resulting from compensation. Which organs again are our main regulatory or compensatory mechanisms? Whenever blood pressure drops, whenever cardiac output drops, whenever oxygen drops, what organs or systems respond right away?
Kidneys, heart, right?
All right, so we have epinephrine norepinephrine will be released by the adrenal glands. That's on top of the kidneys. Then your heart automatically responds to those hormones, increasing heart rate, causing vasoconstriction. Then also in the same adrenal glands, we have the renin-angiotensin system. This time the lungs take part, kidneys take part. So angiotensin 1 becomes angiotensin 2, causing vasoconstriction, and then the aldosterone is released in high amounts, causing reabsorption of sodium and water, thereby increasing blood volume. So therefore, you see there all three, right? So we have the all three elements of perfusion there, as mentioned here at the beginning here. So the compensatory mechanism will increase preload, increase afterload, and increase contractility. Right? These are all in response to the trigger, which is the cardiac output dropped or blood pressure dropped, blood volume dropped, whichever trigger. So the body responds in all three. So the heart rate increases, blood vessels constrict, and the blood volume increases. Okay. So that's long story short. Please read on your own. These are the explanations here about what we just said. Now we have the progressive now. If the patient doesn't receive any intervention, so let's say when you had a heart attack, Tatiana had a heart attack, but then she chose to have it in the middle of a desert. She was out in Arizona or maybe in Utah. Okay, she's admiring the landscapes. She's out there visiting the parks, and then she has a heart attack there. Now she was dropped there by she took the bus there. I don't know why the bus would be there in the desert, but no, that's what she did. So she took a bus, and then the next she'll be scheduled to be picked up 12 hours later, right? So she's stuck there. So all the while her body's trying to compensate. Is there an infinite compensation? Do our compensatory mechanisms have an infinite period?
No.
No, it can only last so long. So here in progressive stage, obviously, either we did not identify it or the patient had no access to healthcare. Okay, maybe they're stuck at home, becomes unconscious. So here, there is obviously a failure of the compensatory mechanisms now. Okay, so they were overworked. The duration is just way too long without any treatment. So now we're here on the progressive stage. All is not lost though. We can still, if somebody gets to this patient at the progressive stage, there's still, we can still do heroic interventions here. We can put them in ICU. We give them massive amounts of fluid. We give them vasopressors. Okay, so we increase preload, we increase afterload, and we give them inotropic agents to increase heart rate, increase contractility of the heart. We can still save this patient. However, if we don't, then they go into the next and final stage, which is the refractory stage. Nobody comes back from this stage. Not only are the organs anoxic, because the oxygen debt has been going on so long that multiple organs have now died. So there is now already cell death, and of course these cells are found in multiple organs. So now you have more than one organ that failed. There's no coming back from this. Plus the sequelae now comes in. Now you develop DIC because this is now a very extensive cellular injury. So now DIC comes in. Plus you go into ARDS. We'll discuss DIC, and well, you guys already covered DIC last semester. ARDS will cover under gas exchange. It's a terrible state. It's also like shock. It's a state. ARDS, it's a condition, and that is actually what most COVID-19 patients die from. They develop ARDS, so their lungs fill with fluid that you can't oxygenate them very well. You need a lot of oxygen, a lot of PEEP, a lot of um, pressure in order to deliver oxygen with each breath. Okay, it's very hard to treat. So here's a summary of the signs and symptoms that you'll see per stage. So question on exam would be identification. Question could go, the nurse knows that the patient is now in the progressive stage of shock when she observes which of the following. And there you go. Be careful though, because they just increase in severity. The patient has the same symptoms. Here you have neuro symptoms here. So you have, obviously this is cerebral hypoxia because now the patient has restlessness, confusion. They just get worse here. So if you compare compensatory to progressive, these are the same systems, just more pronounced when you go to progressive stage. Look at the urine, for instance. Here, you still have 400 ml here per day. This one here, you go now to 100, 0 to 100, right? So they just get worse. Again, all these stages here are applicable in all types of shock, except which one again?
Sepsis.
Septic shock.
Okay, so don't include septic shock here. All the other types follow these stages. Okay, we will discuss septic shock separately. Questions so far?
No.
All right, let's move on. So shock isn't that easy to treat. Again, our best chance lies during the compensatory stage. But again, when we reach progressive stage, we can still save the patient. Just put them on ICU. And then we do our monitoring. So let's discuss now what are our findings. So this will be a continuation of the table we looked at earlier. So this one now gives you the explanation. So we start from restlessness and confusion in the compensatory stage, and then you end up without treatment, which is now in, that means we're in the progressive stage. So now you have lethargy and coma. I won't read the whole thing for you. You're responsible for reading. So base this on the table right here again, the table 14-1, I think. No, that's classification. Right here, 14.2. Okay, so the stages of shock are explained in the next paragraphs that follow here. So from CNS to cardiovascular, respiratory, renal. So we said they go from oliguria and then become anuric. There we got anuria as we progress, as we enter into the progressive stage. Let's review hemodynamic monitoring. I discussed this in heart failure, so let's review it again. Patients in shock need internal hemodynamic monitoring. The only way you achieve that is using a Swan-Ganz catheter, or this is called a pulmonary artery catheter. We also need an arterial line. They have specific functions. Okay, arterial line can also display blood pressure. However, pressures in the heart, inside the heart, can only be monitored using a pulmonary artery catheter. Arterial line, this is usually put in an extremity, usually in the forearm. The radial artery is the easiest access site. So they'll put in an arterial line, very useful. You can draw ABGs from this line. You can draw blood. You can administer medications there, but most importantly, it's monitoring peripheral blood pressure. Okay, arterial blood pressure, but this one is monitoring it peripherally. Pulmonary artery catheters measure the blood pressure inside the heart, inside the chamber. So there are two readings here. We have, demonstrate. So let's say this is, who you want this to be? Okay, this is G. Okay, so we put the artery catheter through here. So this is Mr. Wang's heart. So we have the catheter threaded to the jugular inside, and it stops right here on the pulmonary artery. Okay, as it goes to the pulmonary artery. There are two holes here. This is the pulmonary artery, and then let's say this is the tip of my catheter. So there are two openings. One here, this is number one. This one here, number two opening. So there'll be about 5 lumens here.
Are you drawing something? We can't see.
I can't see it.
Look at the
I can't see.
Could you scroll down just a little, Professor?
Okay.
No, this is not what I want. Where's my... this one. Okay, can you see this one?
Yes.
Can you see Mr. Shi?
Yeah.
Okay.
Yeah, sorry, my mic was muted. I didn't notice.
Okay, so so this is where it is inserted on the neck. So this is the jugular entry. Then we have a so this is the catheter, and it has up to 5 lumens. So 1 lumen is for the balloon, because we need the balloon to insert this thing, and then we have the main infusion port. Infusion port is to administer medications, because we can also use this for that. And then one will be for this is the PA catheter, and then this one is for CVP. They will be on the tube. The tip of the tube, there will be labels. You'll see CVP written on this one. This one will say PA, meaning that's your main pulmonary artery catheter. This is usually yellow. This is blue, and I forgot the other colors, but there are different colors. So here, since this number 1 hole is in the PA, so therefore, if you attach this to a transducer, a pressure monitor, it will give you pressure right here on the left side. So this is right side, this is left side. So it gives you indirect pressure in the pulmonary artery, through the pulmonary artery, meaning you can measure the left side heart pressure because the lungs are here. So whatever happens to the lungs, they will reflect on the pulmonary artery pressure. And the central venous pressure, this is another hole right here. So since there's a hole, you can also attach this to another transducer. Actually, it's the same monitor. So this will be attached to the same monitor, giving you the pressure. Okay, so this one and this one is attached to your transducer. So it gives you information real time, what's happening inside the heart here. So you can see if the patient is going into right side heart pressure or left side or right side heart failure. So the pressures there are constantly being monitored in real time. So you don't have to wait for crackles to appear or the patient to have pink frothy sputum. Okay, you can see it in real time. You see on the monitor what's going on inside. So that can be the difference between treating the patient early or if you're too late with your interventions. So I described, here are your ports. This is not testable. These are all nice to know, but just know that you have these multiple. Oh, it's right here. Why do you have to draw it?
I think your drawing was better. Your drawing was better though.
No.
But this one only has 4 ports. You're saying that they have 5.
Yeah, this is a cheap one. They only have 4. They can only afford 4. Okay, so these are the ports. Okay, so you have the distal balloon. Anyway, so this is the tip of the catheter that I was trying to explain. This will measure your left side because it's situated on the left side. So whatever's happening in the lungs are reflected on the pulmonary artery pressure. And since you have a hole here, the other opening is in the CVP line is here. So this will tell you pressure on the right side. This is not very safe to insert because there's no guide wire. As you can see, there's no room. See, there's no option for a guide wire, meaning when the doctor inserted this thing, this is done blindly and he's at the mercy of luck. Because what the doctor will do is as soon as he's inside, he'll just inflate this balloon and then pray it reaches the pulmonary artery catheter because the blood will take it from there. So it'll just be carried as long as the balloon is inflated. So the balloon will be like a sail. So it will carry the catheter and all he's looking at is the pressure monitor and just hoping again this because this thing can coil. Let's say we're here upon insertion, this thing might not advance to the right ventricle. This could stay here because the heart doesn't stop beating. So this could be bouncing around here. So you have to do it again. So if it doesn't advance, that means the catheter is inside here. So you have to pull it out again, try again, insert it again.
Professor, is this done at bedside?
ICU or in the ER. I've never seen it done in the OR. I mean, it's not necessary.
Okay.
Yeah, this is at the bedside.
Okay.
All right. Central lines. On top of the PA catheter, we need central lines also. But if you have a PA catheter, that should suffice. Okay, I mean, you have a big catheter there. You can also give medications to a pulmonary artery catheter. That if they don't have one, mostly younger doctors don't like to put in swans anymore, PA catheters, because there are other ways you can measure it. They have better techniques now. They can see it on EKG. I don't know how they do it, but they have a formula in order to determine the pressures. It's not the best though, because they're all estimates. So the I don't want to say gold standard either, but the best pressure you get is still from a pulmonary artery catheter. They can also do echo, less invasive. They can do a echocardiogram, and then they can measure the pressure that way too. But again, not as good as the pressure you get from a pulmonary artery catheter. Labs. Okay, so since shock is a state of anoxia, hypoxia, oxygen debt. Okay, so always remember shock, the patient has oxygen debt. So we said when the body goes into anaerobic metabolism, that means there's still an oxygen debt. You haven't paid back the oxygen yet, right? So of course, as long as there's anaerobic metabolism, lactate levels will continue to rise. So this will be your monitoring here. So you constantly draw ABGs from the arterial line, and then you also draw blood there to look at your lactate levels. Okay, so these two levels must be constantly monitored, meaning this is the only way you can evaluate whether or not the patient is getting enough oxygen. Okay, if our interventions is improving blood pressure, improving perfusion. Okay, when I say oxygen debt here, we're not talking about lungs here. The lungs typically have no problem. It's really the delivery of the oxygen here that's the problem. It's the oxygen getting to the cells because again, shock is a blood pressure, a perfusion problem. It's the delivery of the oxygen. Gas exchange may be perfectly normal, but the delivery side, the supply chain. Okay, let's put it that way. So you constantly draw lactate levels and ABG. Okay, look at your pH because both will give you good information. And of course, if you're in lactic acidosis, that will reflect on your pH. 14.3. If this makes sense to you, okay, let me explain this thing. So in hypovolemic shock, what is this problem again? Is this a blood volume, vessel, or a pump problem?
Low blood volume.
Okay, so this is a preload problem. Look at your hemodynamic numbers. Does it make sense that the central venous pressure or the right atrial pressure drops and the pulmonary artery pressure also drops? Does that make sense?
Yeah.
Okay, because again, hypovolemic shock is a preload problem. This is a volume problem. Is there a problem with the vessels here in hypovolemic shock?
No.
No, that's why do we have vasoconstriction or vasodilation?
Vasodilation.
Vasodilation.
Oh, no, again, vasodilation only occurs in 3 problems. We have neurogenic, anaphylactic, and septic shock. Okay, don't confuse it. Hypovolemic is what problem?
Oh, vasoconstriction.
Yeah, this thing only has a volume problem. This is only affecting preload. So therefore, there's no problem with your afterload here. There is sympathetic nervous system stimulation. So you have vasoconstriction here. You have increased heart rate here. Make that clear. Okay, let's move on to cardiogenic shock. Now, this is a pump problem. Did the patient lose fluid?
No.
No.
This is a contractility problem. Since the heart is not contracting, what happens to blood movement in and out of the heart?
Decreases.
Decrease.
Therefore, what will happen to the blood movement inside the heart?
It's also decrease.
So therefore, will there be congestion of blood, or is there good blood flow?
A congestion.
So what will the pulmonary artery catheter register?
It'll be increased.
All right, so that's why there is increased right side and left side heart pressure here. So you have high right atrial pressure and high pulmonary artery occlusion pressure. But because this still stimulates sympathetic response, there is vasoconstriction. So you have increased SVR. But one thing in common in all of these is all of them have decreased output, except this stage here. That's why it really, this is what I mean by in septic shock. That's what makes it very hard. Is this thing is weird. Look at this. This is shock. Why would there be increased cardiac output here? And why would anybody in their right mind say increased cardiac output? That's a bad sign. Why the hell would you say that, right? Increased cardiac output is good. So are you saying this patient is going bad or getting worse? Just looking at that, increased cardiac output, can you say somebody's going bad, downhill, or getting better?
Getting better.
Better. Okay, so this is the part where septic shock is deceiving, and then they go downhill after that. But generally speaking, again, if you look at this table, all have decreased cardiac output, decreased cardiac output, decreased cardiac output, except this part right here. Okay, and then I'll discuss this. We'll come back to this later. We were at cardiogenic. Let's look at obstructive. Cardiogenic and obstructive are identical. There's no difference if you compare them, because whether the pump fails directly or indirectly, the pump failed just the same. Would you agree?
Yeah.
All right, so that's why they're identical. So here, whether it's direct pump failure or mechanical failure, meaning something outside the heart, extracardiac mechanical obstruction, the findings will be the same because the pump failed regardless. So there is elevated right atrial pressure and PaOP. It just says variable here because it depends on the cause. So for instance, if the cause is cardiac tamponade, then it will be elevated. But if the cause is, let's say, tension pneumothorax, wherein it compresses the superior and the inferior vena cava, it can be lower because now you have low venous return. Okay, so that's what makes it variable there, because it depends on the cause. But they all have vasoconstriction because these trigger sympathetic response. Let's go now to the 3 distributive. So they're also the same. Look at here. Why is there low hemodynamic pressures? And bear in mind that in these 3, you have vasodilation. That's why there is decreased SBR, decreased SBR, decreased SBR. There is no vasoconstriction here. All these guys have vasodilation. And that's really the direct cause why you have direct decreased cardiac output. Remember, these patients did not lose fluid, unlike here in hypovolemic, wherein you lost preload. Here, preload is normal. There is normal preload here. But the problem is, the vessels, the pipes, are way too big than your total blood volume. Right? That's the main difference here. So under normal circumstances, if the vessels had normal shape, normal size, we have enough blood volume, we have enough preload. But then if you enlarge the vessels, do you still have enough preload to fill them?
No.
No more. It's like now bringing a sack instead of a small bag. Okay, a regular bag wherein you put your stuff in, you put your tablet in your backpack. Now inside the backpack, your mom gave you a big sackcloth, 100-pound capacity sackcloth. Okay, so now you don't have enough resistance there to generate blood pressure. Are you with me so far?
Yes.
Yeah.
Okay.
Yeah.
All right.
Yes.
So any question about these hemodynamic numbers?
No.
They just look weird like this, but if you read it, it makes sense. Who has difficulty? Or any question? What is right atrial pressure again, Miss Linda?
Right atrial pressure is like the pressure on the right side of the heart, right?
Very good. And PaOP is?
I forgot what POP is.
Well, if
The
RAP
left
is
side.
the right side,
The
then
left side.
The left.
that's the left side.
Mhm.
Yeah, because we can't say left atrial pressure because it's impossible. How can we put this catheter in the left atrium, right? We
Yeah.
can't. You can only put it in the pulmonary artery catheter because you can't go beyond that. Okay, that's pretty much the end of the road for the catheter because the vessels get smaller. They turn into capillaries as they enter the lung. So you can't bring it there and then bring it back. All right, so your catheter has to end at the tip of the pulmonary artery. Okay, if we don't have question there, let's move on. So those are your hemodynamic numbers in shock. Again, we need them in order to, 1, assess the problem. And more importantly, the second purpose is to evaluate the response to our therapy. Is our therapy working? Are we giving them enough fluids? Are we giving them enough vasopressors? Okay, enough inotropic agents, because that will determine whether or not therapy is effective. The interventions here are now discussed by type according to each shock. Generally speaking, this is pretty simple. So if you're losing blood or fluid, what do you think will we give the patient?
Blood or fluid.
There you go. So this is pretty simple. However, there are drugs involved here because what if they don't respond to the IV therapy? So now you need drugs. Okay? But your initial therapy would be replacing what was lost. So if you lost water, so let's say Palliavi had a really bad case of diarrhea, 16 times an hour. Then she was also vomiting the same amount. same frequency, so that's pretty bad. So we'll have to give her those. And at the same time, she fell and then hit her head on the toilet bowl during the vomiting, and so she's bleeding at the same time. So we'll give her blood transfusion as well. Yeah, I'll just let you read the management on your own. By the way, everybody gets oxygen regardless of shock, because of course you have oxygen debt, so you need oxygen, right?
Yeah.
There is a drug here. Oh, by the way, this is evidence-based. This is kind of weird. They called something here. What is this? They call it permissive. What was the term? Let me see if I can find it. It's not here. Probably in the next. Oh, right here. Permissive hypotension. Okay, so this is during the fluid resuscitation. I encourage you to read this on your own. This is a strategy here, postulated to reduce post-resuscitation mortality and morbidity. Meaning there's a plan here, I mean a technique wherein instead of, because our standard is we want a mean arterial pressure of 65. No matter which textbook you read, they all say 65. But then there's a technique being used now of keeping it low, which I don't think anyone really wants to do that. Because whether it's head injury, shock, or any other critical patient, the standard has always been 65. We want mean arterial pressure to be 65. Okay? So it's up to you if you want to believe this, but this is just something they put in here. Did I miss anything? Okay, so this is now the nursing part. Again, these are all about monitoring and maintaining fluid resuscitation and or blood product administration. The parameters or the indicator that you monitor whether or not you're giving enough IV therapy are your hemodynamic readings, your urine output. What's the normal urine output?
30 mLs per hour.
Yep. Or if the question says 0.5 mLs per kilogram, that's also correct. Okay, the normal urine output should be 30 ml per hour or 0.5 mLs per kilogram per hour. Because if the patient is heavy, we may not be contented with 30 ml because of course they're bigger, so they need more than 30 ml per hour. So now we base it on 0.5 mLs per kilogram per hour. Let's say your patient is Shaquille O'Neal. You're not gonna base your urine output on that guy on 30 ml per hour, because you have a lot of real estate there, right? So the blood has way more space, more real estate to cover rather compared to me. Okay, so it's probably close to 50 ml per hour or more. As already stated, everybody gets oxygen. And that's it there. Let's go to cardiogenic. Now, the management of cardiogenic shock is technically in acute coronary syndrome. It's in a different chapter. All right, just giving you a heads up. So here, this one is more narrow. Okay, in chapter 14, it's narrower because the discussion here is really under acute coronary syndrome, under under STEMI. Okay, so this will be a condensed version here in chapter 14. So your signs and symptoms are those, of course, of a patient with heart failure. Okay, so patient who has a heart attack. Management, obviously we need, because this is a pump failure. This is direct pump failure. So we need EKG, cardiac enzymes. So this is what I mean by it's very narrow here. They don't talk about all those anymore because they're discussed in the acute coronary syndrome chapter. Medications, again, the same as mentioned for a patient having an MI, which are, what do we give patients with MI?
Nitroglycerin.
Okay, we give them vasodilators. Do we give them inotropics?
Yes.
Yeah.
Yeah.
Mean,
Digoxin.
right. So the the vasodilators here are nitroprusside, and then big time diuretics because they need their preload down. So this is some exceptions here. Okay, so in all other types of shock, do they get diuretics?
No.
No. So only cardiogenic shock patients receive diuretics. Because try giving diuretics to a patient in hypovolemic shock. Let's see what happens.
No, you're killing them.
Yeah. But you understand why we give diuretics here, right? Because this is shock. This is cardiogenic shock. But why give diuretics?
Because of the blood congestion.
Volume.
All right, because the nature of cardiogenic shock is there is high afterload, there is high preload, right? So therefore, our treatment will be the opposite. We decrease preload, we decrease afterload. That's why we give nitroprusside, we give diuretics, we give inotropics, right? Because this is a pump problem, so slightly different. This one is, yeah, boss.
What about beta blockers and stuff in order, because earlier you said that there's the release of catecholamines and everything in a shock condition, but does that not happen?
Yeah, but remember in ACS, is beta blockers indicated during acute MI?
Oh, okay, no, you're right. Thank you.
Yeah, don't forget that part, boss. Because remember, we need it to compensate initially. Okay, so beta blockers are not indicated in the acute stage though. Post MI, yeah, we give the beta blockers already.
So Professor, cardiogenic shock is an acute shock.
Yeah, because this is MI. Remember, the number one cause is MI or a dysrhythmia. Yeah, so cardiogenic shock is always acute. Actually, all shocks are acute. All right, so here you don't see beta blockers here. We can use calcium channel blockers. Okay, that's not contraindicated. So you can skip these. These are not. These are already on the discussion for MI. So that's why they have the intra-aortic balloon pumps. What else? PCI. See here, cardiac catheterization. So that's already tested previously. I have a pigeon in front of me. Get away. Okay. Please read the drugs on your own, okay? I won't do it again. These are the same drugs used in a patient with MI, but this one, because the MI, the death from MI really is from cardiogenic shock.
Professor,
yes.
You have a drug book in your syllabus, but I believe we never used this drug book before.
Say it again.
The drug book in your syllabus, pharmacology, it's, what's the author? I don't know if we used this book before.
Oh, that's fine. I mean, whatever drug book you have now. because I can't keep track of which cohort is using what.
Okay. Thank you.
Because when we switch to Davis, we also switch to the Davis drug guide. I think there's a drug guide instead of drug book. Yeah, Davis drug guide. Okay, obstructive shock. The treatment for obstructive shock will depend on the cause. So let's say it's pericarditis and cardiac tamponade. So what will be your treatment for obstructive shock?
Treat the obstruction.
Okay, so you treat the cause here. So so this will be the only thing that separates this from other forms of shock, is because you have to treat the cause in order to treat the shock. So for instance, if this is caused by a tension pneumothorax, what would you do? Will you give drugs?
You would relieve the pneumothorax. So you would
Right. So you do emergency thoracotomy, right? Needle thoracostomy, and then followed by chest tube insertion. Does that make sense?
Yeah.
Okay. So that's your management here. But as we looked at the hemodynamics in the previous page, it was identical to with cardiogenic shock. So here, as far as management, it will be depending really on the cause. So here, if you have cardiac tamponade, then you do pericardiocentesis. If you have tension pneumothorax, you give you put in a chest tube. If it's massive PE, then you give massive PE is treated with either thrombolytics, or if contraindicated, then thrombectomy. Okay, because these are really large clots. Like you can really literally put it in your hand. Okay, these are big clots when we say massive PE, not the tiny ones that are under submassive PE that you need a CT angiography in order to see. These ones can even be seen on regular CAT scan. But everybody gets oxygen, like I said. So see how quick the obstructive shock is? Because really you treat the cause and then you resolve the shock. Okay, distributive. So this is not septic. Septic will be in the end. So let's start with neurogenic first. So keep in mind, neurogenic shock, these are all blood vessel problems. We have massive vasodilation here. All right. So although the patient did not lose fluid, the patient looks like they are hypovolemic because we have very large blood vessels. Okay. So to put it in perspective, it's like using a really extra large condom on a 12-year-old penis. Okay. So it's like that. So you don't have enough blood volume to fill the really large pipes, right? So this is what we mean by relative hypovolemia, because the blood volume is normal. Okay, the patient didn't lose fluid; they still have 5 liters or more of blood. However, the vessels are just way too big, so there's no pressure. We cannot generate enough vascular resistance in order to generate enough blood pressure. So it's specifically in neurogenic shock because of the injury to the vessel, to the spinal cord. There is now unopposed parasympathetic activity. So this thing here leads to vasodilation and bradycardia. So if you see, all the other types of shock have increased heart rate and vasoconstriction, correct?
Yeah.
In neurogenic shock, so this is a trivia here. This is the only shock that has bradycardia. All other shocks have tachycardia, even anaphylactic shock, because it triggers sympathetic response also. Okay, except this one, except neurogenic shock. This is the only one that has bradycardia. Just like cardiogenic shock is the only shock that receives diuretics. So that's another trivia there. So, another thing here is distributive shock. If you look at skin manifestations in hypovolemic, cardiogenic, obstructive shock, they have cool, clammy skin. They look pale and their skin feels moist and cold. Why? What happened?
Lack of circulation.
Because of circulation.
Okay, because every other shock has vasoconstriction. These three here, neurogenic, anaphylactic, and septic shock, have vasodilation. So of course, instead of, oh, by the way, the reason why they call this distributive shock is there is a faulty distribution of blood here. So what is the purpose of sympathetic response again? What is the body trying to do? Why did the body respond by triggering the sympathetic nervous system? Why are we constricting blood vessels? Why are we increasing the heart rate? What
For
is the
compensatory measures?
Where is it? What is it trying to do with the blood?
To send it
Get
to
blood flow to the body.
and the brain.
Okay, so we're trying to shunt the blood only to the vital organs. So we want to bring the blood to the brain, the heart, the lungs specifically, because those are the major vital organs. Is the skin a vital organ?
No.
Yes.
No,
Yeah.
but look at what's happening in, look at what's happening in neurogenic, anaphylactic, and septic shock. Is there proper shunting of blood? Is the blood being shunted to the vital organs?
Yes.
No.
No.
Where is it bringing the blood? It's bringing it to the skin. Look at the manifestation. The patient looks flushed. They look red. Because even the skin, is the skin a vital organ?
No.
No. See, the patient has a warm, dry skin. So even though they're in shock, they look pretty. They look pink, you know. Of course, these people aren't smiling, but their color is beautiful. Hold on a minute. All right. So here, that's why they call this thing, these types of shock under distributive, because there's a faulty distribution. Okay, that is, instead of distributing it only to, or shunting it only to the heart, the lungs, and the brain, these three types of shock are distributing it to everybody. It's like socialism, you know. We don't care whether you're a vital organ or not. You're part of us. You're gonna get blood, which is not very efficient, of course. Management for neurogenic shock is symptomatic, because we cannot. I mean, there's spinal cord injury. You can't fix that. So the management is to support it, because this is not long term. This is just in response to the episode. As soon as you develop spinal cord injury, this occurs as part of the injury. So look at your interventions. They're not designed to cure the problem. Unlike in cardiogenic, for instance, you treated the heart attack. In Miss Palevi's case, she had diarrhea. You give something to stop the diarrhea and the vomiting, or stop her bleeding. Here you stop this thing, so you just do support here. Treatment is focused on providing cardiovascular support. Okay, that's all you can do. The spinal cord injury, it just has to run its course. So the treatment are dopamine. So you have vasopressors, epinephrine to cause vasoconstriction. So you can say these are vasoconstrictors. And then we give fluids also, IV fluids, because here, cautious though. Why do they say cautious fluid resuscitation?
To not increase.
Okay, because remember, the patient, did they patient lose fluid here?
Not really, no.
Remember, they have normal preload. They have normal blood volume. It's just that relative hypovolemia occurred because of the vasodilation, remember? So now, what if the vessels go back to normal now and you're giving all these fluids before that happened?
You're going to have overload.
You tend to have fluid overload here. So cautious fluid resuscitation, especially if you're giving these drugs, because the moment they kick in, then your patient all of a sudden will go into fluid overload. And because we have bradycardia, if the patient becomes symptomatic, then you already know the treatment. You did this last semester. And that's it. That's how you take care of neurogenic shock. The problem there is really identifying it. So after spinal cord injury, then you monitor the patient for this type of shock. So you monitor blood pressure, plus you look at the heart rate. Oh, by the way, trauma is not the only cause of spinal cord injury. It can also occur with epidurals. Okay, so when you're having an epidural procedure, especially if the nurse gives an anticoagulant within 24 hours of a epidural, that can cause a hematoma to form in the spinal column. Because that hole, I mean, you've seen, not everybody, I mean, those of you who've had an epidural, was it a tiny needle that they used?
No.
No. Big ass needle that they put in your spine. So that hole that they created when they inserted that needle takes time to close. So that's one warning. Do not give anticoagulants within 24 hours, because that hole will take at least 24 hours to close. So until then, the patient may develop bleeding in there. And once you have a big hematoma there, that increases intraspinal pressure, and it causes spinal cord injury. Please look at the nursing interventions on your own as far as positioning. Let's say, in all types of shock, how do you position the patient? I forgot to mention that part. So anybody who has a low blood pressure, how do you position them? Do you elevate the head of the bed?
Would you do Trendelenburg by any chance?
Well, that's depending. So let's say you have spinal cord injury. Is that a good idea?
No.
No.
So what's the safest position for any patient in shock?
Would it be just flat?
Semi-flowers?
Well, flat's not going to improve venous return.
No, elevate the head of the bed.
Elevate the head of the bed. Remember your intervention for hypertensive crisis? That drops blood pressure if you elevate the head of the bed.
Yes.
So how do you
elevate the legs?
Very good. We call that modified Trendelenburg. Elevate the legs.
Modified.
That will increase venous return, increasing
circulation of the blood.
Yeah, because you improve venous return there. All right, let's go to anaphylactic now. So here, this is, these shocks are life-threatening. Okay, so this one just looks scary, right? Because this happens so quick. So the patient is sent to either food, medication, or any other substance. And then they develop massive inflammatory response leading to a release of a lot of histamine at one time, causing widespread venous dilation, capillary leak. That these are all going to be responsible for your manifestation here. So if it's flushed, there will be bronchoconstriction because remember the sounding like a bird. Okay. What was I saying? Oh, okay, here. So So in anaphylactic shock, so we read there that there is widespread vasodilation because of the histamines. And so if this is your bronchus, remember the bronchus, the airway, your trachea is made of smooth muscles. So these are muscles. So they have capillaries there. So if the capillaries become leaky, capillary leak syndrome, and there's vasodilation. So if these vessels here dilate and become leaky, the result will be like this. So the walls here will thicken. There is now edema. So instead of your airway being this big, it'll now be this big. So that will account for your signs and symptoms here of wheezing, stridor, cyanosis, confusion because of hypoxia. But you look pretty though. You look
cold, charming.
warm, flushed. However, if untreated though, then as you die, you become cold, pale, clammy. But during your acute episode here, there is flushing. Okay, so there is flushing first, and then as you get worse, then you look horrible.
Professor, I have a question.
Yes.
Have you ever seen a delayed anaphylactic reaction?
I mean, me seeing it?
Yeah, or like anybody. Because like not for me personally, but what do you call this? My nephew has a food allergy. So he had a really bad delayed anaphylactic reaction that took hours instead of acute.
Yeah, there is
various thing.
Just like in blood transfusions also, you also have delayed transfusion reactions.
Okay.
So yeah, there is a delayed hypersensitivity reaction. Yeah, it just took time for your body to respond. Treatment. This is an emergency, so oxygen, then you have your epinephrine first line, IV fluids followed by vasopressin. We can also give steroids and Benadryl. Steroids can be POIV or even inhaled. You got that? So emergency, you give oxygen and then your IV epinephrine, followed by, if there's no order for vasopressin, then it will be the Benadryl and the steroids. But you understand why we give vasopressors, right? Because the problem here is massive vasodilation. Right? Okay. They're preferred because IV epinephrine has a short half-life. So there can be rebound vasodilation there. So that's why they do vasopressors, because they last longer. As far as emergency action, depending on the situation, okay? Because it can be, the setting can be in a hospital. So let's say my question is, in what order will you perform your interventions? So if it's an IV antibiotic reaction, what is your first action? Do you go for the oxygen or
Just
stop the
stop.
transfusion,
You gotta stop
Transfusion.
right?
You
Of
have to
course,
stop
stop
about it
it,
first.
and then you proceed. Just like here. So if possible, remove the trigger. So if there's a trigger, the medication is the trigger, of course, you stop it. If it's a thing, then you try to, if you can see the stinger, take it out. Of course, we don't have oxygen at home, and there's no, I've never seen a bee inside a hospital. Um, Plus, bees are disappearing anyway. They're gone. We're next.
But they said they have these deadly hornets coming from Asia. I don't know.
Yeah.
Yeah, but they're not exactly efficient pollinators, so, and they're gonna kill us too.
It's coming with COVID.
Hit on site. Yeah, choose between COVID and hornets.
Mm-hmm. Yep.
Praying mantis can kill the hornets.
The what?
Praying mantis can kill the hornets.
Do you have any?
They said it can kill human too.
Well, the UFOs could kill the praying mantises.
All right, let's go to sepsis. So there are, thank you for reading this part here, just because this one is what complicates the outcome in sepsis. Thank you for reading. Miss Carol Chung.
Sepsis and septic shock are two clinical conditions on a continuum that starts with infection and ends with septic shock. In worst case, disseminated intravascular coagulopathy, DIC, a hematological disorder associated with enhanced coagulation and multi-organ dysfunction syndrome may result.
Okay, so technically the death here comes from either so you die from DIC, meaning you bleed to death, or you die from this dysfunction. And somewhere along here, we will also read about acute respiratory distress syndrome, ARDS. That's another possible cause of death here in sepsis. All right, so if you read this whole paragraph, which is long, I'll summarize it. So first you have a local infection, then becomes systemic. And once systemic, now it activates your cytokines in order to stimulate your immune system. Okay, so inflammation occurs first. So during the release of these inflammatory cytokines, they do it in such an overreaction, meaning it's not commensurate to the injury, meaning the body responds here in a really hysterical manner by releasing so much inflammatory cytokines that these things cause vasodilation, right here, vasodilation, and the capillaries become leaky. Okay, so that's really what triggers the whole thing here. It's not just the infection, but the body's response. So if you heard on TV what they're trying to do with COVID patients, this is the part that they're trying to stop. They don't want the body to be reacting this way. Okay, I mean, it's to a certain extent, yeah, of course we want inflammation, but not so much inflammation. Okay, so this is really what's causing the patients requiring to have mechanical ventilation because there is so much fluid in the lungs now. So the battle here, it's really your immune system causing it. Of course, the trigger is the COVID-19 virus, but they don't have to react this way. You know, the body doesn't have to do it this way, but it does. It causes capillaries to dilate and become very leaky, and as a result, fluid accumulates in the lungs because the alveoli are wrapped in capillaries. If you look at the live lung tissue, it's so red because there's each air sac is wrapped in capillaries. So if all these capillaries become very leaky, then of course you'll have fluid in the lung. All right, so blah, blah, blah. It leads to more vasodilation as because if this happens locally and then once infection becomes systemic, now you have systemic vasodilation, systemic capillary membrane permeability. All right, and then during the battle, when the bacteria or the virus and your immune cells start fighting, they cause even more fluid and exudates to produce. Okay. So let's look at the sequelae. So on top of what's happening there, now the injury or the severe inflammation causes this second part now. So this will now trigger clotting. So this is now the start of your DIC. So you have here protein C, activated protein C, and antithrombin 3. So this is the first part of DIC. Okay. So protein C causes you to form clots, right? And then here, because after you form clots, the body starts to break it down, resulting in D-dimer levels now in response to as a result of clot formation. Eventually, you're gonna run out of clotting factors. And then that's the second part of DIC. So as soon as after you consume all the clotting factors and the platelets because you were forming clots, now you have nothing left, bleeding follows. Okay, there are two stages mentioned here. So of course, sepsis starts from stages. Unlike in the other stages of types of shock wherein they have initial, compensatory, progressive, and then refractory, there's no such equivalent in septic shock. So in septic shock, they have a completely different stage. There is, of course, the local infection, then we have early sepsis, okay? So in early sepsis, which is right here, early septic shock, there is a hyperdynamic period. Okay, again, this is part of the early stage of septic shock. You become hyperdynamic. If you remember the table we looked at earlier with all the hyperdynamic numbers, you recall that? And I pointed this out.
Increased heart rate.
Remember the table earlier with each type of shock, and they all had decreased, but all
yes.
SVR.
Yeah.
Okay, so go back to that and look at it here. So in early sepsis, they become hyperdynamic. So this is what I mean by if the stages of shock is in early sepsis, unlike in other types, so let's say in this is your mean arterial pressure and this is time or stages. In other types of shock, if you go from initial to compensatory to progressive to refractory shock, what happens to the mean arterial pressure? It goes down like this, right? Very easy to see. You can clearly see, oh, my patient's getting better. I mean, getting worse. Look at my MAP. So 2 days ago, he was here. Yesterday, he was here. Now, I better call the family and to say goodbye. In sepsis, it doesn't work like that. So here we have early, and this is now late. Let's do an example. So let's say you're here for pneumonia, okay, which is a common cause of sepsis. What do we give them on admission?
Antibiotics.
We give them oxygen, we give them Do you have any reason to suspect that if the MAP, so let's say here they started here, or initial, like let's say they had pneumonia, not septic yet, no sepsis yet. So in pneumonia, the MAP was low. And then next day, they go like this. Are you telling me that they're getting worse? My MAP went from low to high, and I have antibiotics on board during this period. So I do have any reason that this rise here, this hyperdynamic stage, is early sepsis and not a improvement of pneumonia?
No, it's misleading.
Of course it is misleading, because how else would you monitor this? I mean, interpret this. No, I gave antibiotics yesterday and then today. So of course my patient improves. So I will never, for the life of me, suspect that the patient is going into sepsis. Right?
Right.
Yeah, so this is what makes mortality really high. You can't really tell. Look at this. Patients become hyperdynamic. Look, patient looks beautiful. Warm, flush skin. Blood pressure is normal. All right. So do you have any reason? Oh, this is early sepsis, man. Not really. Plus, you have confusion. I mean, that's expected, especially if this is elderly, right? So look at the management shortly. We'll have to look at the other signs here. So you can't really base it on mean arterial pressure because it can be misleading. The patient actually looks good here during early sepsis, but watch what happens now in late stages of shock. As they progress, they go hypodynamic now. And now you have continued anoxia, continued lactic acid accumulation, continued anaerobic metabolism, continued oxygen debt, and then the patient suddenly tanks. So after this period here, wherein they're hyperdynamic, they go straight down when we go to late sepsis. Happens so fast.
Professor Scott, I have a question, but can we see lactic acid buildup in like when they just come in initially, like in the early stages, or no?
That's also the problem, because although lactic acid is a good indicator, it takes time for them to rise though. However, you don't have to rely on lactic acid. We do have other indicators. Look, you know about the protein C levels. So you see doctors monitor these. So when you see orders like antithrombin 3, activated protein C levels, this is what they're trying to monitor. Any patient at risk for sepsis, because they have to distinguish between if they're really getting better or if they're getting worse. So that explains why if you have a patient, because they're not in for sepsis, they're in for something, let's say pancreatitis, for instance, pneumonia. If the patient has any infection and they're immunosuppressed, those patients are the higher risk patients for sepsis. So you'll see doctors ordering these blood tests, which in your, if you haven't seen septic shock yet in a textbook, you'll wonder why the doctor ordering these. That's the reason they're trying to monitor whether or not the patient is in septic shock already, because this early stage here, they're hyperdynamic. Okay, so you have to distinguish whether or not this is really an improvement because of your treatment, or if this patient is getting worse. Right. So that's how you monitor. So interventions. Of course, we have a sepsis bundle. We'll look right here, bundles of care. So any septic patient, of course, the blood pressure has to be maintained. So we give fluid resuscitation. Again, don't forget about oxygen death. So we give oxygen and fluids. And here, our mean arterial pressure must be 65 or more. If not, then we give vasodilation. Okay, steroids. Please read this. Somebody read this, please. Miss Carolyn.
Steroid replacement therapy is controversial. Adrenal insufficiency is a common feature of sepsis, but the use of high-dose steroids has been shown to have no benefit. Their use has not been shown to decrease mortality in sepsis. Studies have been inconclusive as to the benefits of low-dose steroids in septic shock. The surviving sepsis guidelines recommend low-dose steroids if the patient has not been responsive to fluid or vasopressor therapy.
Okay, this is one of those things that Trump has been, which really makes you even angrier. So he started with hydroxychloroquine, right? And then at one point he suggested this too, that the steroids, because some doctors are giving it. So here clearly you see it remains controversial. So there's really no evidence that steroids really suppress the immune system, because remember this part here that we're trying to stop, the reactive inflammatory response. You can't stop. There's no evidence that giving steroids will stop this, because of course we want to stop this, because this is not really necessary. Okay, we don't need the inflammatory response to be this bad, because really this will cause the fluid buildup in the lungs. So but however, at the same point, there's really no evidence that the steroids will really stop that mechanism. Okay, and there's really not enough data that supports the use of steroids. So they have low dose steroids, but again, this is not there's really no clear evidence that is true. So that's why our bundle right here, this is called Surviving Sepsis Bundle. This is from the Joint Commission. This is a core measure right here. But before that, let's finish the IC first. So we already did the IC. This is just to conclude that the patient in sepsis, septic shock, develops the IC, which will complicate your treatment. We already discussed N+ last semester also. So first you have clotting first, and then followed by bleeding stage. So here is your bundle. As you can see, there is no steroid mentioned here. When you read this, by the way, don't interpret this to mean that you have to wait 6 hours before you go to the second line. It just simply says within 6 hours. So the title is Surviving Sepsis. So for your patient to survive sepsis, you have to follow these. So once sepsis is identified, this is what you do. Draw blood first for lactate and cultures, and then start your antibiotics. Fluids, this may not seem like much, but let's say 30 ml per kilogram. If I weigh 70 kilograms, how much fluid are we talking about?
35 ml.
That's a lot of fluid. So this is bolus. Okay, massive fluid resuscitation here. Of course, we already drew blood, so we have our baseline lactate, and this one's for culture because this one's broad spectrum, but we can easily change this. So once we get our sensitivity and identification 48 hours later, we can switch antibiotics more sensitive to against the organism that whatever grows. And if the patient remains hypotensive, even if you give this, then you add vasopressors. Again, don't wait for 6 hours. This doesn't mean, oh, it's not 3 hours yet. Okay, so if they remain unresponsive to this is a lot of fluids and they don't respond to that, then you add vasopressors and then continue with these. But tension persists, you do the same and then give more fluids, more vasopressors, and then you continue your lactate measurement. And that is septic shock. Here's your nice picture of the IC. Remember you guys showing that in your group presentation. Any questions on shock?